Hi, I'm Dr. Amy Krambeck, Professor of Urology and Chief of the Division of Endourology at Northwestern Medicine in Chicago, Illinois. Today I will be speaking on assessing effects of intrarenal pressure and how to mitigate those effects. A little background on what the current dilemma is. Advancements in flexible ureteroscopy have allowed us to treat stones in the upper urinary tract that we never thought were possible before. Laser advancements have allowed us to treat stones larger than 2 centimeters in size and be very effective and efficient at this. There are two main schools of thoughts on how to treat these stones. There's the basketers, which recognize that you want to break up the stone and then pull out the pieces. And then there's the dusters that will dust the stones into small fragments using the laser to allow those to pass later. The dusting proponents claim that there's less ureteral trauma during the dusting procedure, and I think that has been proven to be true. And the OR times are faster, and they do not use a ureteral access sheath, so oftentimes can limit stenting after the procedure. Basketers, on the other hand, claim to have higher stone-free rates, which has often been found to be true in most trials. They do require ureteral access sheaths to extract the fragments. However, this has been thought to result in less pain, most likely due to less pressure in the kidney and less risk of developing a hematoma. There's been a lot of studies on ureteral access sheaths and intrarenal pressure. Previous studies have shown that ureteral access sheaths do decrease intrarenal pressure. One study looked at patients undergoing ureteroscopy with and without a ureteral access sheath and pressurized irrigant of 150 millimeters of mercury. In that study, the intrarenal pressure went from 41 millimeters of mercury down to 17.9 millimeters of mercury just with using a ureteral access sheath. Furthermore, this decrease in pressure was also realized even with manual pump irrigation, which can generate much higher intrarenal pressures. We know that high pressure irrigation above 150 millimeters of mercury results in flattening of the urothelial mucosa, edema of the submucosa, and vacuolization of the renal tubules in the porcine model. Furthermore, at long-term follow-up, scarring has been noted in the porcine kidney when it was subjected to such high pressures. Finally, patients with higher intrarenal pressure at the time of surgery have been shown in the PCNL population to have higher postoperative pain. So this led us to question, what is the pressure threshold? We know that pressure is bad for the kidney, we know that there is damage that can occur, and we know that it's possibly related to pain, but what is the upper limit that the kidney can sustain? So we did a study looking at pressures in the porcine model. We had 10 female pigs, 20 kidneys in total, and the kidneys were subjected to pressure via a ureteroscope at varying degrees. We had three kidneys in the control group, which was standard atmospheric pressure. Then we had 50 millimeters of mercury, 100 millimeters of mercury, 150 millimeters of mercury, and 200 millimeters of mercury. The ureteroscopes were left in place at this pressure for 36 minutes, and we chose 36 minutes because this was the mean ureteroscopy time in the dusting group in the EDGE study. This was all performed in a laboratory setting using general anesthesia. And we tied a silk tie around the ureteroscope in the ureter so that we could maintain the pressure constantly over the time period. We also had a pressure sensing wire in the kidneys so that we could ensure that the pressures were maintained over the time period. When we tried to pressurize the kidney over 200 millimeters of mercury, we found that the kidney could not sustain these pressures. With a rapid rise, the kidney ruptured immediately. We even tried a slower, more incremental rise, and the kidney still could not maintain the pressure. However, the lower pressures from control all the way up to 150 millimeters of mercury were sustained throughout the entire time course. The kidneys were then preserved before harvesting using a special preservation protocol, and then the pigs were euthanized and the kidneys harvested and looked at for pathologic evaluation. Under pathologic evaluation and during the time of renal harvesting, we found that the ruptured kidneys were quite impressive. There was a significant amount of fluid in the retroperitoneum, and in both kidney groups, the kidney had split in half and there was hemorrhage around the kidney. In the lower pressure groups, there was really no gross abnormalities. However, endoscopically, we noted hemorrhage in the 100 and 150 millimeter mercury group on the mucosa only. Microscopic evaluation, however, in the lower pressure groups demonstrated no changes in the cortex, medulla, or urothelium. However, in the 200 millimeter of mercury group, there was significant pathologic microscopic changes. There are areas of tubular compression in the kidney as well as rupture. There was also areas of hemorrhage around the kidney and within the medulla of the kidney. So based on that study, we know that 200 millimeters of mercury seems to cause significant damage to the kidney, and lower levels seem to have no obvious pathologic damage. But what is the clinical effect of higher pressures on the kidney? Well, to answer this question, we really need to understand kidney pain. And kidney pain is multifactorial. When there's obstruction of urinary flow, we have increase in intrarenal pressure and the release of prostaglandins, which can result in pain. A common finding with ureteral obstruction is perinephric fluid. And there's two pathophysiologic theories behind the increase in perinephric stranding or fluid. Either there's a sharp rise in intrarenal pressure that causes a rupture of the urinary tract, what we call a fornicele rupture, and fluid is released that way. Or the increased pressure leads to an increase in renal absorption of fluid, and you get fluid that develops around the space of the kidney that way. Regardless of how this occurs, common to both theories is that there is an initial factor, which is the rise in intrarenal pressure. We do know that in prior studies, pain, use of analgesia, and the total amount of narcotics needed is associated with the amount of perinephric fluid noted on postoperative imaging. We further know that the odds ratio for the need of analgesia after a surgery, such as ureteroscopy, is directly related to the degree of perinephric fluid noted on the postoperative imaging. So the development of perinephric fluid occurs somewhere around the threshold of pilovenous backflow, which is around 20 to 50 millimeters of mercury. To put that in context, the physiologic intrarenal pressure at baseline is around 0 to 15 millimeters of mercury. We also know, based on the pig study, that the kidneys will rupture somewhere around 200 millimeters of mercury, but we still have a large gap between those two values. To further understand what pressure does to the kidney, other investigators have looked at the cadaveric juvenile pig model, and in this study they pressurized irrigation within the kidney and had the irrigation stained with India ink. Then they harvested the kidneys to assess the depth of penetration of the India ink. And they found, very much like we did, that as you increase pressure, the depth of penetration of the ink into the kidney increases. However, when they added a ureteral access sheath, this significantly decreased the depth of penetration of the ink into the kidney and limited the effect of the pressure. We do know that pressure causes pain, most likely based on the prior studies. We do have ways to mitigate pain that are not related to pressure. There's certain medications that have been shown after ureteroscopy to be helpful in relieving pain. Alpha blockers and anticholinergics decrease the renal colic symptoms that are found after ureteroscopy. NSAIDs have reduced postoperative stent pain in multiple different studies, and we know that intraoperative and postoperative use of NSAIDs or steroids can be very helpful in patients. Furthermore, the use of alpha blockers seem to aid in helping postoperative stent-related pain. B&O suppositories given at the time of ureteroscopy may also be helpful in limiting postoperative pain scores, but does not seem to decrease the amount of narcotics needed post-procedure. Other studies have looked at highly selective alpha-2 agonists and found that this also decreases postoperative pain, but it is not a widely utilized treatment method. But intraoperatively, there are things we can do, and I bring us back to the ureteral access sheath. One study of 60 ureteroscopies looked at patients treated with and without a ureteral access sheath for stones less than 2 centimeters in size. And they found that patients that did not have a ureteral access sheath utilized during their surgery had higher postoperative visual pain scores, and they think this is most likely related to higher pressures. On the other hand, when a ureteral access sheath is used, there is concerns about ureteral wall ischemia or ureteral edema, so most patients will frequently get a ureteral stent placed at the end of the procedure. Another way to limit intrarenal pressure is to limit the amount of pressure that we utilize in the irrigation, or to improve the difference between the scope size and the sheath. One study looked at intrarenal pressures at the time of PCNL using a ureteroscope transducer placed in the renal pelvis. The intrarenal pressure was higher when there was a smaller difference between the scope size and the access sheath at the time of PCNL. And that makes sense. A larger scope decreases the ability of the irrigant to efflux from the kidney and increases the intrarenal pressure. More importantly, those patients that were exposed to a higher renal pressure had higher average postoperative pain scores during their recovery period. Ureteroscopy pressures have also been analyzed. In one study, percutaneous nephrostomy tubes were placed in the kidney to measure intrarenal pressure at the time of ureteroscopy with and without a ureteral access sheath. Without a ureteral access sheath, just placing the ureteroscope in the distal ureter alone resulted in intrarenal pressures over 60 millimeters of mercury, and these pressures increased as the scope was moved to the proximal ureter. However, by placing a ureteral access sheath, those pressures decreased to 15 millimeters of mercury. So how we irrigate also plays a role at the time of ureteroscopy. So pressures at the time of ureteroscopy are dependent on the use of the ureteral access sheath, but also on the pressure of the irrigant utilized. The average intrarenal pressure when a ureteral access sheath is utilized is around 30 centimeters of water or less when the fluid is pressurized to 100 centimeters of water externally. Now, if you increase that external pressure to 200 centimeters of water, you will realize pressures inside the kidney over 40 centimeters of water just because you have increased the external pressure. We also know that in PCNL systems with a 4 French or greater difference between the size of the scope and the size of the sheath will result in much lower pressures regardless of how we irrigate. So the ways to mitigate pressure is to keep your external pressure lower or to have a wide difference between the sheath and the scope sizes. So one study comparing PCNL to ureteroscopy also favored pressure as a source of pain. Lee in 2015 compared many PCNL patients to ureteroscopy patients. All patients had a stent at the conclusion of the procedure and no patient was left with a nephrostomy tube. The authors found that in the mini PCNL group, they had lower 1-hour postoperative visual analog pain scores compared to the ureteroscopy group. They also had lower analgesia usage, and the difference between the two groups was mainly their intraoperative pressure. The authors theorized that the decrease in pressure at the time of PCNL compared to the ureteroscopy group was what contributed to the lower pain scores. So in conclusion, we've done a lot of discussion today about increased intrarenal pressure at the time of ureteroscopy. And we know from the pig study that I presented today that over 150 millimeters of mercury at the time of ureteroscopy seems to be the pressure threshold for significant damage in the kidney. But we also seem to realize that lower pressures can cause difficulties for the patient as well. I've shown today that increase in intrarenal pressure has been associated with perinephric fluid development, as well as pain scores and analgesia usage after ureteroscopy and PCNL. We can utilize medications to decrease postoperative pain, but most likely taking measures such as decreasing your pressure irrigation as well as using a ureteral access sheath can limit the intrarenal pressure and decrease postoperative pain. Thank you.